Hello and welcome everyone to another of my radiology videos. For the people who are new to this channel, my name is Umar Shafiq Chaudhry. I am a board certified radiologist and a board certified neuroradiologist who practices here in the United States. I make radiology videos related to didactic topics and career oriented videos for different stages in radiology. The current talk is about fellowship selection in radiology. This is a topic I get asked a lot by people in different stages here in the United States residency system, but also by people overseas who are interested in radiology, by med students, and sometimes even people who have finished their radiology residency and are practicing out in the real world. So without further ado, as you all know, or people who've seen my videos before, I like to start with quote, usually inspirational. And so it's always better to be a diamond with a flaw than a pebble without pieces. This topic or this video is going to be structured in a way where I'm going to just talk about the current landscape and the current radiology market here in the United States. Then we'll move on to what would be the right time to decide about your fellowships, again, oriented from a radiology residency perspective. Then we move on to the factors which I use to help decide and choose the fellowships that are present. And then we'll talk about individual fellowships, what are the pros and cons of those fellowships. We will also touch upon, actually, if you're not willing to do any fellowship or you just want to do what we call general radiology. To sum it up, we'll do some special considerations of mini fellowships for people who aren't really familiar with this topic or people who in radiology residency are wanting to do these. And then we'll also talk a little bit about the visas just in terms of my foreign audience of people who are already here on visas or IMGs. Now, the current landscape, I did discuss this on my last video as well. The current landscape in radiology is amazing for radiologists. Now, this can change and it is like a pendulum, so it does keep changing back and forth depending on what the market is like. Right now, we're doing a lot of studies. AI has not caught up with it. The radiology residency programs that are graduating residents are usually not enough to fill those spots up with the exponential rise in the imaging demands across the country. Not only that, but the expectations for the turnaround times are increasing, and that leads to a higher demand. There are, however, a lot of challenges, and as you know, I do have a video that will be coming up on AI and radiology, where I do talk about the challenges that AI faces currently and maybe in the next decade for job market relation or radiology. Now, in terms of the current landscape, like I said, it's a great time to be a radiologist. You have a lot of opportunities available. There are challenges which can relate to reimbursements and which certain practices are facing. And I do have a separate video on how to choose the right job depending on what your preferences are and also angled or aimed at the current job market. So without further ado, let's get started. Now, what is the right time to decide on a fellowship? Well, for people who are not familiar with this, in the United States, usually fellowships get decided in the third year of residency. And again, going back to my pathways, radiology is a 5-year track. The first is a clinical track, and then we have 4 years of radiology residency. So within the third year of those fourth year pathways, which should technically be a PGY4, or your third year of the actual radiology residency, is when you decide on the fellowship. That's when you're applying for the match. That's when you're interviewing and then ultimately deciding on it. So it's a year before you graduate. Now, when to apply can vary a lot. It can vary by the competitiveness of that fellowship, which I will be getting into in a little while, where you're applying, whether you're applying in-house, whether you're applying somewhere else, and to what ranked program are you applying to outside, right? So as the name, as it's pretty obvious that if you're applying to something that's not as competitive maybe and not to a mid-tier program, it's something that you would want to do, then you can wait a little bit. You don't have to really jump the gun for that. However, sometimes in-house applicants, the in-house people want to know very early in the third year whether you're going to be joining them or not. And so you may need to decide earlier. Similarly, if you're applying for something like maybe that's participating in a match, it's kind of out of your hand, and so you have to basically wait for the match application when it comes out. And so there are certain specialties, although there are fellowship options which are available outside the match as well, but traditionally, neuro and IR have been the ones that participate in the match a lot. Breast is another one, or the mammography, imaging, MSK, and ER also have certain programs or places that do participate in the match. Now, what are the factors by which you decide on what to do as a fellowships? So the first thing I always tell my residents whenever they show up to me and they're like, hey, Dr. Shari, what do we should we do in terms of a fellowship selection? I always tell them the first prerequisite is be honest with yourself. Forget about what the job market is like. Forget about what your, peers expect you to do or your mentors expect you to do. Just have a deep introspection. What do you like doing? When I was a second year, I was given an interesting piece of advice in radiology residency, and I was like, hey, I'm divided between neuro and MSK and certain two specialties. One of my seniors told me, hey, what do you like doing more? Reading back-to-back knee MRIs or reading back-to-back spine MRIs? Or to phrase it differently, which would you rather have? So it's basically things like that. You want to do a mental exercise of things that you want to do in radiology, things that don't bore you as much, maybe, or things that really excite you. That would be the perfect ideology. So that is my first factor that I always advise people to do. Now, always be aware that just like medical school or medical college, you may come up with certain ideas or certain expectations when you start, right? So there are a lot of people out there who start off by thinking, "Hey, I'm going to be doing surgery. I'm going to be doing a certain specialty," and then when they go into that actual medical school, they start doing rotations. They think, I do like this other specialty. So always keep yourself, open to this, and don't be hard on yourself that, hey, I came into radiology thinking I'm going to be doing neuro. I came into radiology thinking I'm going to be doing IR, but I don't like it as much. Expect that to happen. That you are not an anomaly. That happens to a lot of people. So just be open and honest with yourself. Now, that brings me or piggybacks to another point, which is not to commit too early. This is another mistake I quite see residents make quite often, is that they'll come into a program their first week, the second week they'll be, talking to their peers, talking to their seniors, talking to their attendings, and they'll be like, yeah, I want to do neuro, I want to do neuro, I want to do neuro, I want to do IR, I want to do MSK, I want to do, et cetera, et cetera, et cetera. That is all well and good. I'm not saying that you shouldn't, is something that is prohibited, but you have to understand that that basically boxes you in very early. So even though you have an idea on what you would like to do, my advice would be to just experience all the rotations. And if somebody asks, tell them, hey, I am interested in a certain field. I haven't decided yet. That is absolutely normal. And a lot of young residents feel like, a stigma or almost taboo to talk about this and say, oh, what if I'm in a neuro section and I don't like neuro, or I'm in IR and I don't like IR. Give everybody a chance to not commit early. Now, the other point that I would like to consider is another taboo point or something that residents don't want to talk about, and that's the quality of life. Listen, I understand that, if you ask for a certain lens on a certain thing, people may misconstrue that as being something or somebody who doesn't like to work. But there is a fine line between being lazy and being actually efficient and also realizing what is the best thing for your current situation. So, when we talk about quality of life, this is not a taboo topic. This is not something you cannot discuss with your attendings. You do talk to them. Hey, you can, an approach that I quite often tell my residents to say is that, you can talk to resident XYZ or senior resident XYZ or fellow XYZ or even attending XYZ and say, I like neuro IR. I have seen the different facets. What is it like practically? Are you facing any challenges with your family, with your work-life balance? Because remember, if you get into something that you like, but it really is burning you out, you won't be able to do it consistently, and that creates a vicious and a bad cycle that you don't want to get into. So don't underestimate asking or thinking about quality of life when you're making this important decision. The other things are more objective and more practical. That is to consider, okay, how many patients or what's the volume that this certain section faces, and when I'll be going into each specialty, I will be addressing this. These are also the parameters basically by which I'll be talking to you all about. what you should be doing, what you shouldn't be doing, and or at least my take on this, all right? And so the amount of patients, procedures, that can be a big factor to influence as well. That certain sections have a larger volume, certain sections have more procedures, and that can be applied to that. And then finally, of course, is the job market. Now, what do I mean by that? It is a pendulum swing. So job market does change back and forth, but there are certain specialties which will always have a very niche and maybe a limited amount of job market. And it may be something that you like a lot. Great job. But at the same time, this is one thing that I will include in my considerations when I'm talking about different things. All right. So then before we get started on all of the individual specialties, I just want to give a disclaimer. We'll be talking about the pros and cons, but please, I don't want anybody to get offended. I don't want anybody to say, hey, I don't think that's a pro. Good for you. This is my personal take. This is my advice I give to residents. I give it with a grain of salt. If you like it, great. If you don't like it, go with what you think that is best for you. There are a lot of variables in life and a lot of variables in fellowship. One situation may vary from one or the other. Somebody's pros is somebody's cons. So take it with a grain of salt. I think that this would be informative for people out there, especially radiology aspirants, radiology residents, people actively applying, we're thinking about fellowships. We see this quite often asked. So take it with a grain of salt. Man is what he thinks he is? No. Man is not what he thinks he is. Man is what he hides. Interesting quote by Andre. All right. So without further ado, let's get started on our first specialty, which is neuroradiology. Now, as you all know, I am a neuroradiologist, but I've tried to make it as unbiased as possible, and we will go forward from it. Now, what are the pros in this specialty? The pros is that you get tons of exposure of neuroradiology during your residency. Doesn't matter whether this is a small program, a mid-tier, or an upper level program with a high volume, you will be exposed to neuroradiology. So you get a lot of, exposure to what the specialty is like, what it entails. Now, because of the heavy volumes, because you get so much exposed, you can, take it for granted that the volumes will remain high and the demand for this will also remain high. There are a lot of areas within neuroradiology, so you can go into tumor, stroke, head and neck, and spine. And I think this will actually be sort of a recurring theme. A lot of specialties have further areas in which you can subspecialize, and neuro also has that. So neuro has a lot of imaging that there are people who do tumor imaging a lot. There's head and neck, which is very specialized. Another advantage of neuro is that it's not only a diagnostic specialty, it does have light procedures, as we like to call them. And light procedures usually mean fluoro-guided lumbar punctures, fluoro-guided lumbar punctures with contrast, which is myelograms, or even sometimes biopsies or pain procedures. This is also another pro that this could be a stepping stone for doing neuro IR, which is a separate pathway from diagnostic or vascular IR. So that requires currently in the United States for you to have done 1 year of neuroradiology fellowship. So this is a good stepway for that as well. The last point ties in with the high volumes, high demand. Because of this, neuroradiology positions are very widely available. A lot of institutions have multiple options for fellows, and therefore, in terms of deciding the brand of your fellowship, deciding the location of your fellowship, that makes it a little bit easier. Now, coming to the disadvantages. The disadvantages are that neuro basically is very ER heavy. And so what that means is that a lot of the neuroradiology jobs that you will be doing expect you to be there 24/7, which means you will be doing some shifts, which are evening shifts, night shifts, day shifts. Having said that, of course, that can vary. You don't have to do all those shifts. I, for instance, have not done nights since my residency is a personal choice, but you have to remember that neuro jobs will require swing shifts, odd hours, or evening hours for it to be equitable for everybody in the group. The other thing with neuroradiology that it has procedures, light IR procedures, that are actually not always outpatient. Many of these procedures are inpatients. Many of these come over the weekend. Many of these come over the night, and some of these are not deferrable. So you may have somebody with a cauda equina syndrome who cannot get an MRI. Well, that may mean an emergent, myelogram. And so that is one thing that you may or may not be on call for, and that's something that you run into. There's going to be some turf issues if you have IR. A lot of people in IR that I know do not like covering for other specialties, especially neuroradiology, so you may end up doing that. So that's one thing to consider as far as a disadvantage. Another disadvantage that I see is, I think it's a little understated, is that with neuroradiology, because there's so much exposure in residency, because so many folks do this in their residency, people feel that they do are very well versed with it, and you'll see a lot of people trying to read these, even IR, breast people, and everybody else. Many cases that's fine. I obviously am personally biased because of doing a lot of this for the last decade or so. There are a lot of nuances even in even simple exams, but definitely for complicated exams like head and neck or tumor cases, nobody's going to touch those. But just so you all know, there is a lot of cross coverage that can be available just because the demand is so high. People are exposed to this quite often, and they feel like they can do some of the studies just to help out. And in many instances, honestly, we have so much to go around that most neuroradiologists don't mind that. There are also very heavy volumes of stroke and CTA studies, which is a big thing that, it's something that I work on. It's sort of my pet peeve. I do work on efficiency of stroke imaging. However, this is not changing in the near future. So there's a lot of CTA and stroke imaging, which may be cumbersome exams. So during your residency, if you feel like CTAs are something that you're completely averse to, neuro may not be the best place for you for that. Now, because it is so popular, despite of its demand, there is competition either in the fellowships as well as in the job market as well. So good spots maybe have a lot of competition because there'll be more candidates to apply for that, and generally you do compete with more people. But like I said, because of its widespread era, there are positions that almost always are available. Now we move on to interventional radiology. So interventional radiology, interestingly, when I was thinking about a fellowship, this was one of my choices, whether I should do that or not. Again, I come from a surgical background. This is something that I had seriously thought about. But there are certain disadvantages which finally persuaded me not to follow it as such. So what are the advantages, first of all? It is an incredibly procedurally heavy specialty, as the name suggests. In fact, I would say it's predominantly a non-diagnostic specialty where you do a lot of hands-on work. It's like a surgical, basically, specialties. You do get exposed to it in many programs here in the United States and also overseas for that matter. And so you do get to experience the actual intricacies of it. What are the pros and cons of it? For people who don't have a lot of IR exposure, I really would advertise you to actually do away rotations or do rotations where you do get exposure to IR. But in my personal experience, that's very, very rare. With the ubiquitousness of IR everywhere, it just is something that you will get exposed to, and so you can get an idea to it and get involved with it. The other advantage of this is that this is very high in demand. It is something that a lot of people want as fellowships. The job market is great for IR people. Now the areas can also vary, so there's another advantage again, like a recurring theme I talked about. I have friends who are amazing IR people who focus a lot on the liver and the biliary system. There are people who are doing MSK, interventional radiology, or some other stuff as well. So there are variable areas within this as well. And there is, of course, going back, there's a lot of patient contact, a lot of clinical work. You can run your own clinics. I have friends who run their own clinics in IR, and you basically are, like I said, more of a clinical person. The diagnostic aspect of this is much less. So people who have come into radiology and aren't like sitting down a lot, I would, no, ideally those people are not that many. But again, if you come into radiology and you're like, okay, I came into it, but this is definitely not my jam, and I'd like to be moving around. I'd like to be, out there. Then this is definitely something for you. And then finally, a very important point is that this is one of the specialties of IR of radiology that's very AI resistant because it's hands-on. So definitely you have more scope in terms of the AI challenges with that. Now, what are the disadvantages? The disadvantages are that there are certain training pathways currently in the United States which have you commit very early. which is the direct pathway. And a lot of IR programs are offering that. And this is something that they really want you to kind of zone into or become a part of. So when you sign up for that, you basically sign up for IR as soon as you start your residency. So early commitment is a requirement for that. And I know a lot of people and a lot of residents who have done maybe 3, 4 years of direct pathway, and they're like, hey, we do not want to do IR. We definitely want to go into diagnostics. Now that's possible, but does make it a little more difficult for you to do that. So early commitment is, I think, one disadvantage. The other disadvantage, as the name is, that it's a quality of life issue. It's you're on call, you're carrying the pager. There's no IR job where you don't have the pager. And for people like me who don't like that hanging around their head, I think that this would be a big disadvantage. Personally speaking, this was the straw that really, broke the camel's back for me, because I was like, this is the reason I left radiology. I wanted predictable hours. I don't want to be on call when I'm not working, and that's basically something that you really cannot avoid in IR. The other advantage can also be a disadvantage, which is the clinical lifestyle. You interact with a lot of patients, and so that could be a disadvantage for some people. And then one other important point, which is a disadvantage, is the turf issue. So there's an old slogan. It's been said many times, is that interventional radiology, it says, inventing procedures for other specialties since the 1970s. And that's actually not untrue. There are a lot of procedures that interventional radiology invented, but then were taken up completely by other specialties. Vascular radiology, for instance, is an old nemesis of IR, and TEVAR, for instance, for the aneurysm repair, that was invented by interventional radiology and taken up by surgery. Similarly, you have to understand that for a referral system, you need a good clinical base. A lot of times, the specialties like nephrology, neurology, vascular surgery, they have a higher clinical base, and it's much more easier for them to siphon easy outpatient cases, high embarrassing cases for themselves, where you're left with basically just collecting kind of the remnants of that. There are people who are combating that. I think IR breaking off into its own demi specialty, completely divorcing from radiology, may be the right way to go forward. I have really good friends who are very aggressive in this, who really want to get their own clinic started. They actually shop out for it, but there is no denying that that becomes a much more of a factor in interventional radiology, where you're actively fighting for the patient population. You're fighting with the specialties to kind of create awareness, to get a good referral base. Now, the other disadvantage is that it is very competitive, and because it's competitive, you can sometimes get more competition and fellowships. So it may be that you may not be able to match in the right area in terms of geographical considerations or the ranking of that program, and you may not like the program itself. So it's a little competitive. In fact, not a little, but in fact, I correct myself. It's probably one of the most competitive specialties right now, because of the surgical aspects to it. All right, then we move on to musculoskeletal radiology. So this is basically for people who are studying, is radiology that deals with mainly orthopedic surgeons, sports medicine. There's a lot of plain films that comes with it. What are the advantages? Because there's so much exposure, you will get exposed to it. Now that exposure can be variable in my experience, but you do get exposed to it. This is one specialty that cannot be cross-covered very easily by non MSK people, and especially cross-sectional imaging. You will not meet a non-MSK radiologist who will be like, oh yeah, I'm very familiar with the ankle MRI or a knee MRI. We tend to generally avoid these, as opposed to like a lumbar spine MRI, which body folks or other people may sometimes pick up as well in neuroradiology. The other advantage of this is that there are a lot of outpatient, because it's sports medicine. These are injuries that are usually more to do with morbidity rather than mortality. So, they can wait for the next day or an outpatient basis. And you generally have less patient contact as compared to neuro, for instance, or breast, or definitely less than IR. And so if this is something that, you could be a pro for certain radiology types. And then because of its outpatient system, you actually don't get a lot of pager call. So that's a big advantage as well. Now, what are the disadvantages? This can be very niche, and so you may not have that much of a job market as compared to maybe like neuro or IR or emergency medicine, because people, generally need to have a higher sports or orthopedic base. for that. You because there are low volumes, you will be asked quite often to cover non-MSK things, so neuro, ER, body. You will be asked to do that. Plain films are a big burden. They don't reimburse as much, but they do have a strain. So a big portion of you will be reading redundant plain films back and forth, post-operative films, which can be a little boring. And then, some locations or programs don't have this opportunity available, so it may not be something that is available at your residency. It might not be available in your geographical area. There are some non-ACGME programs as well, so the application is still a little variable. Now we move on to women imaging, also called breast mammography. This was another consideration when I was thinking of, fellowships. I do really like the advantages of this program. One of the biggest advantages of this program is that it is a niche field, so general radiologists feel very intimidated by it. They would not like reading a lot of it, mainly because this is federally mandated here, and therefore it has certain reporting requirements. The big advantage again is lifestyle. There's a very good work-life balance. It's predominantly outpatient. There's no call, almost infrequent call. You may end up in a private practice which does have the same amount of call as the general radiologist, but those are rare. Generally, breast imaging, women imaging is treated differently even in the call pool. So you have infrequent or less frequent call as opposed to maybe a general radiologist. One of the advantages, but like I said, could be a disadvantage to some, is that you have a lot of patient contact. In fact, when you're doing women imaging here in the United States, it's almost like running a clinic. So every day you're talking to 10 patients or more, depending on what your clinic goes in. So you're counseling them, you're talking to them, and so you get a lot of patient contact. It is also very, very procedure heavy. So you do a lot of needle localizations, you do a lot of biopsies, you do a lot of aspirations. So every day you're doing a lot of procedures. So it's very procedure heavy. In fact, after interventional radiology, if there is any field which is very closely related to it, would be mammography. So it's something that is your cup of tea, and you really do like patient contact procedures and all that stuff. This would be a good specialty. Now, what are the disadvantages? The disadvantage is that it can be a very high pressure job, interestingly, because you're dealing with a small asymmetry, cluster of calcifications, and those can turn out to be very life threatening. So it is a very high pressure job. It could also be medical legally very challenging for you, because you may be sued a lot, and so it is a very high pressure job. The other disadvantage I find is that although it is a high pressure job, the approach is very algorithmic. So if it's a certain type of calcification, you're actually bounded by law to describe it in four types. All right, so you can't really go out of that. So it's very algorithmic. If that's the way, this is the next way. If this is the next step, this is the next step. Now, what that means, and I talk about this in my AI radiology thing as well, that this algorithmic approach, the more algorithmic a specialty, the more easier it is for AI to take over it. So therefore, this potentially could be one of the things which AI participates in a lot, although the procedure element may take away from it. The patient interaction, I've included that in pros and cons. So, depending on your personality, you may not like to talk about that many patients. You might not like getting up from your chair again and again and again to talk to patients and counseling them about it. A lot of times the interactions that happen are very high anxiety interactions, so you may be giving news that are potentially life ending, or very earth shattering for that person. And then the last disadvantage is that there's such a large volume of this currently, and that you tend to get away a lot from general radiology. So yeah, until and unless you're doing very frequent call or moonlighting or some night duties on the sides, I know a lot of people in breast who actually are not that well versed with anything outside of that specialty, and so that may be that it can erode into your general radiology skills. Now we move on to body radiology. Body radiology is radiology about the systems, and you'll rotate through that. There's a high demand of that, so that's one of the advantages of this specialty. It's also a relatively 1 year pathway. When I say a 1 year pathway, most fellowships are 1 year pathways, but neuro can be a 2 year pathway. IR can be a long pathway as well. So this is one advantage like any other. It's a 1 year pathway. It's high in demand. because of certain disadvantages that I'll be discussing. Usually, in my experience, body imaging fellowships are fairly easy to secure, so you could end up in a very high-rated program and do that. The patient population and interaction can vary a lot. There are body programs which are called body slash light IR, where you do tons of IR work. But I know body programs like my, place where I was working at UTMB, where body folks actually don't do any procedures as much, and so it can vary a little bit. But technically, there are some procedures involved. You do a lot of cross coverage, so a lot of times you're not really, doing only body. You're doing a lot of ER work. You're sometimes reading plain films and all that kind of stuff as well. So there's, good cross coverage that you can do as a pro as well. Now, what are the disadvantages of it? The volumes are immense. It takes much longer to read the programs objectively. The individual reads, and so the individual exams take longer, and their volume is high. So that can mean long hours, either in fellowship or in job, in your market as well. And so that can be a high pressure job, and that relates to why it's not very often used. It is also one of things like ER where you're doing swing shifts, night shifts, because ER is very heavy as well. So again, it's something that depends on what your taste is, what your interaction during radiology residency is, and what you would like to do. Pediatric radiology is something that is the advantages of this specialty is that it is hard to read by other people, especially certain conditions, the way the skeleton grows. There are so many differences between pediatric radiology and general radiology that a lot of times I know a lot of general radiologists who are very hesitant to read a lot of pediatric exams. Again, an advantage is that it's a 1 year pathway. It's not a very high in demand specialty, so it's easy to secure. You could get into a higher program, so a high rated program is there. Interestingly, pediatric radiology involves a lot of patient contact, so reducing interception to HCUGs, you'll be dealing with a lot of patients, a lot of patient families, and so you do get a lot of patient contact. There's a lot of general radiology, different specialties, so you still keep in touch with that. Now, what are the disadvantages? The disadvantages are that the pediatric radiology, interestingly, although it's very common, it is centered in mainly academic areas. So the volumes are not as high in certain practice environments, and the demands can vary. Also, I know a lot of pediatric people who have ultimately ended up in academics, mainly because academics is where the pediatric radiology mainly gravitate to. That's not to say that I don't know a lot of pediatric radiologists who are out there in private practice. They are, but just the way the dynamics work is that you end up not doing pediatrics then because your volumes are not enough to justify that. Because there's not a lot of people in pediatric radiology, a lot of times the hours are pretty bad. You may be called in at the night for interception and all that. And Again, just going back to my point, when I say bad hours, this is not, you could land a job which has purely outpatient pediatrics. Not something that I've heard of, but it is possible. So there are rarities out there. What I'm trying to quote here is that what is the general consensus on this, or what is generally, it does have odd hours, ERRs, maybe even worse than some of the neuro and body specialties, mainly because you are less amount of radiologists in that area. The patient interactions in pediatrics are very different as opposed to just similar to breast. There's a high pressure environment, but at the same time you're dealing with somebody, not only the patient, usually like 3 or 4 people, and so it's very hard to convince your patients, as opposed to an adult convincing them to do a procedure. Try convincing a 4-year-old or 5-year-old to void so you can get NDA VCUG. So it's hard, and so the patient interaction can be challenging, and that's something that, just like medical college, you have to basically decide on yourself whether this is something you can or cannot do. Then we move on to cardiac radiology and chest imaging. Now, this is something that, again, is not advantages that once you specialize in this, other people will not meddle into your field a lot. They don't like or are not comfortable in reading this. It's also a 1 year fellowship. A lot of times, these jobs are not prescribed to, so you will find them in higher academic programs as well. Usually, they're not that hard to find. The patient population and contact can vary quite variably. So I know some cardiac and chest programs that do a lot of patient interaction, some that don't do anything. So that's very variable. I would say put it somewhere in the middle. And then you can learn a lot outside of residency in this, because the one of the disadvantages I'll be talking to, you don't get a lot of exposure to this necessarily in every residency program. So there's the learning curve, in my own opinion, and when I've talked to people, is quite high in radiology. You learn many new things as opposed to any other fellowship, but specifically in chest and cardiac. Now, what are the disadvantages? Again, just like pediatrics, the volumes are low, so the demands can vary. It can be limited only to academic centers, again, because those are big enough to employ them. Um, because of the low volumes, to meet up the numbers, you may have to cross cover many times body and other areas where you'll be like, hey, I just want to do chest, but they'll be like, no, you're gonna, we don't have enough coverage, or you don't have enough volumes to do that. Finally, an understated topic, but your radiology residency is probably this is one area where it's the most variable. There are some programs who are rock stars in chest and cardiac, and they get a lot of exposure. There are some programs who've never heard of cardiac imaging because cardiology does all of them. So the program and your residency exposure can vary, which can be a disadvantage in not knowing what is entailed with the actual day in and day out of this. Now, what are the last specialty we'll be talking about is emergency radiology. So this is kind of like general radiology, but it does deal with emergent procedures. So there's a lot of exposure, just the way in residency. It's easy to secure. It's not something that's subscribed to a lot. There is very little patient contact. This is probably one of the fellowships that does the most remote work. The demand can be very variable. Some programs, some teleradiology firms love to hire ER people, some may not, because you're ultimately considered more of a just like a glorified general radiologist. That's not to diss on ER folks. I know people who've really done that, but just because you're doing so many coverages, it's very hard to like subspecialize in one thing. Odd hours in this, there's no getting away from that. You will end up doing most likely nights. The burnout rate is high. So these are some of the disadvantages. Now, with the current job market, there's been a lot of trend, and people in a lot of our forums have been asking, what do you think about not doing a radiology fellowship? Is it necessary? The short answer is yeah, you can avoid it. You don't have to do it. There's no definite compulsion for you to do it. But the way the radiology residency traditional pathway is structured, really, before you can do your certification exams and then later on, the final, it does take a while. So, in that rut of things, one more year doesn't really add up to it. So if you ask my own personal opinion, I would say just do a fellowship, just get something that you like to do, and then you can end up doing general radiology. But it's very hard to go from the other way around, doing general and then trying to subspecialize later on, and to do that. So advantages, just to go over our things, is that it does cut down a year, so you'll start earning in a year. You'll still have to do 5 years, but yes, one less year than usual. There is almost exclusive content and access to prior practice early on, and you can do whatever specialty you like doing. I will say this: my own personal experience is that if you come from a strong radiology residency programs, those are the people who most often point to this, and they're like, oh, we had a very strong radiology residency. We don't need that. Believe me, whatever subspecialty you end up doing, no matter how strong you feel like as a fourth year, there are so many nuances to it. So I think especially in a quality-driven world where I do advocate quality reporting to, distinguish yourself from just, commodity, this is very important. But, again, if you are a strong program, you can, coming from a good general base, you could potentially do that. Right now, it's possible, but the disadvantage is that if the job market starts falling, you know, general radiology may not have a good landscape in the future, and it's very hard to go back into fellowship. Your academic opportunities are less. So, my video on academic versus private practice, what are the, opportunities? So, it's academics is something that you're interested in. General radiology, usually your chances are pretty slim in landing one of those things. And finally, it's hard to basically negotiate with certain groups and reading responsibilities. You're kind of given, you're a general radiologist, you got to do what you do, fellowship by, shift wise, procedure wise, so you don't have that much of clout in terms of negotiation, and you end up really being more specialties. So we'll end our topic with a few rare scenarios. This is just a funny quote I like telling in between my presentations. But mini fellowships. So mini fellowships for people who are outside the residency system or who haven't started their residency yet is these are small extra rotations you do as a fourth year. So basically, you can think of this as extra rotations. They can vary quite widely. If done right, they are supposed to be putting you into extra rotations as an extra fellow, not just an extra resident. But that's easier said than done, mainly because you have been there for 3 years. So they see you as a resident. So when you show up for your extra neuro, your extra MSK, or extra IR rotation, it's very hard to convince them to treat you as a fellow. They'll treat you as a resident. But this is a great opportunity to kind of get, exposed to different things. You may be going into general radiology and then you want to do certain specialties more. You may be doing, for instance, neuro and you want to do MSK. You may be doing IR and you want to do, build up on that or do some other specialty. So they mix and match a lot. This is something that I would advocate all of my radiology residents to think about, actively. This is something that you can talk to your program about implementing more efficiently. The program directors are usually open to this. Decide on this. And really, what you want to do is if you're going into a fellowship, I would, advocate maybe doing an extra month of that fellowship as well, so you can get a running start in your fellowship. But also remember what you want to do after you graduate from your fellowship. So if you are only doing academics and you want to do academics only, then what I would advocate is keep doing the same fellowship. Get yourself really involved in that. But let's suppose you want to do prior practice or you're not sure, then I would want you to experiment a little bit, build up on the weak areas. So, for instance, you may be very strong in MSK and not as strong as neuro. You may be strong in neuro, but not as strong as body or MSK or breast. Do that fellowship. Now, there are people out there who use this as an additional pathway to get nuclear medicine. I am a very good friend of mine did that. Um this is something debatable. Honestly, in my own opinion, nuclear imaging is not as widely available, and that's why we didn't really kind of discuss it in this as much. And so you don't have that much of a job market in nuclear medicine, and getting extra certification on that really doesn't give you too much of a value, honestly, out there. PET CT wise, you don't really need that many to get certified. If you can do that, great. And so you can mix and match this. And my advice again would be to do something that you think you may be weak in. Finally, I'll end this. I myself was a foreign medical graduate. I did a traditional pathway. So I do like to talk about this. This, I think, is also informative to program directors, to senior residents who have colleagues or who have people who they're going to be hiring in different specialties. So you have to remember that the two visas currently available are the H-1B and the J-1 visa. J-1 technically makes it easier to do a 2-year pathway, and H1 makes the 2-year fellowships like an academic neuroradiology fellowship or ESIR pathway challenging. There are ways around it, but just keep it in mind depending on which visa type you are in. I wouldn't want you to just go into a visa type based on your fellowship selection, but this is again something that I wanted to bring up. J1 makes it easier to do that, but later on it can be a little bit of a pain. So I hope that this was informative to all of my people and my listeners. Thank you so much for listening to the video to the end of the video. Please remember to subscribe, like, and click the bell icon for your remember to keep you updated on these videos. I hope to bring you more content in this. Thank you so much. Have a wonderful day.